Good morning, everyone. It is a privilege to be here today to discuss the role of AI-powered tools in early recognition and antimicrobial management of sepsis. I am Dr. Faran Ahmad, Assistant Professor of Medicine at Creighton University, Omaha, Nebraska, and I'll be uh, participating in this CME activity today. I do not have any financial disclosures for this CME activity to share with you. I will not reference trademark or marketing names of therapeutic modalities or pharmacological agents. Our discussion will focus on some key areas that include challenges in the sepsis diagnosis and limitations of traditional methods. We will highlight the AI models for their early identification of sepsis. Moreover, we will talk about integrating these tools into clinical workflows. And then finally, evaluating the performance of these AI tools and addressing the challenges in their adoption. Sepsis and septic shock remain significant challenges in general hospital settings, where delayed recognition often leads to worse outcomes. Evidence demonstrates that timely, evidence-based interventions significantly improve survival. We will also explore some key areas that we can focus on to help identify the sepsis sooner. Now we know that there are various scoring systems. For example, QSOFA, SOFA, News, and Muse, and these are there to help diagnose sepsis in a timely fashion. However, all of them have some key limiting factors. If we look at the key parameters that go into these scores, most of them are related to vitals. However, some of these scores include labs, including white blood cell counts, as well as kidney functions, liver functions, and platelet counts. A study conducted in Norwegian Emergency Department highlight the delay in diagnostic procedures, and we can see that the adjusted analysis showed that reducing the time to antibiotic is crucial, emphasizing the need of predictive model to guide interventions. In primary care settings, this prospective cohort study conducted in 4 out of our primary care service centers in Netherlands between 2018 and 2020 explored the possibility of including various clinical markers and biomarkers to predict sepsis sooner, at least within 72 hours of developing classic clinical symptoms that were part of the inclusion criteria specified as acutely ill patient with fever, confusion, deterioration, due to suspected severe infection. We can see that there were various cutoffs that they set, and they looked at the sensitivity and specificity for adding each cutoff point. And the key predictors that were added onto this study were primarily age, vitals, oxygenation, saturation, mental status, all of them got 1 point. And if we look at this table, we see that as we go from um, 1 marker to 5 marker, even though the specificity goes high, but sensitivity decreases. However, we can see that biomarkers alone did not significantly improve prediction accuracy, underscoring the importance of comprehensive clinical evaluation. It also highlighted that isolated scores like SIRS, QSOFA, and News were not that much sensitive as compared to AI-based continuous models that were utilizing all these clinical parameters in the study settings. AI models that we are utilizing to diagnose sepsis early and coming up with a management plan ahead of time are based on electronic medical record. And we have found that 80% of clinical data in those electronic medical records are basically non-structured free text. These are not labs or markers. These are actually the clinical judgment. For example, a physician evaluated a patient and wrote his assessment, and those assessments are basically non-structured information. So AI-based natural language processing models were modified to identify and extract these medical events which were different from the exact data point and utilize those unstructured text data to evaluate and then come up with the early prediction model. One of those prediction models included the Sarah algorithm. So the way it worked that it utilized the electronic medical record and split that information into structured data and unstructured data. Primarily, the structured data included vitals, labs, and medications. And unstructured data was primarily the information written in the chart by various care providers. And those unstructured topics were further classified into 7 different categories that included clinical status, communication, non-clinical status, social relationships of the patient, uh, overall combination of symptoms, and ongoing treatment plans. Now we can see this comparison of sensitivity of algorithm versus physician and early prediction of sepsis. Now this table shows the timelines starting around 48 hours prior to the actual onset of symptoms and comparing a physician with AI model. And we can clearly see that AI based model was outperforming the physicians in all these early prediction hours. So the system proposed a combined workflow integrating the information in the epic in the form of obvious data points like vitals, labs, and then combine that with these background AI models so as to generate trigger alerts at the time of key events. For example, shift change, or in case of any emergent changes in the patient's clinical status, generating an alert in the electronic medical record to alert the physicians to act accordingly. Now, apart from early diagnosis of sepsis, one other aspect of utilization of these data-driven AI models include early specification of diagnosis. Just taking an example of typical community-acquired pneumonia and trying to identify the exact etiology, whether it is viral or bacterial. In order to do that, this prospective study was done in a single ICU over the course of 18 months. What they exactly did was the collection of all these data points on patients who ultimately had a confirmed diagnosis of viral or bacterial infection, or a combination of these two situations, as well as those unidentified cases of community-acquired pneumonia. So they built the initial dataset based on all the clinical information available within first 3 hours of presentation, and 80% of that information was subclassified to generate a work dataset, and the rest of 20% of information was utilized for external validation of these datasets. The work dataset information was further divided. Half of it was provided to ICU experts, and based on that initial information of the clinical data points within first 3 hours, they were uh, uh, asked to come up with the most likely initial diagnosis, whether that community-acquired pneumonia is viral or bacterial. And similarly, the information was also provided to this data-driven algorithm, which was an AI-based tool to come up with the same answer, the whether that pneumonia is viral or bacterial. So both these arms of the study had their own results, and these results were compared with external validation. The study results were reported in the form of positive and negative likelihood ratio. And we can see that the positive likelihood ratio for bacterial pneumonia, for example, the AI was performing better than in the clinical prediction of experienced physicians. Similarly, when it comes to a negative likelihood ratio for viral pneumonia, the algorithm built from the data sources performed better than experienced physicians. So we can see that studies based on these initial data points within first 3 hours of presentation, where the AI models were utilized, obviously the AI-based mathematical algorithms perform better than physicians in predicting the etiology of severe community-acquired pneumonia. A study published in Lancet Digital Health earlier this year highlights how integrated AI systems serve as antimicrobial learning platforms fostering real-time decision-making and improving patient outcomes in resistant infection cases. They were looking at six key steps which are involved in selection of the appropriate antimicrobials and then utilizing the AI models to predict selection of antimicrobial resistance early on, and then based on that information guiding the physicians to select appropriate antibiotic therapy, and then monitoring the ongoing antibiotic therapy for any harms or side effects, and at the same time diagnosing any emerging antimicrobial resistance in the background. To deal with antimicrobial resistance effectively, AI integrated care systems were proposed by this study. These systems can guide antimicrobial stewardship by leveraging machine learning to optimize therapy pathways and reduce misuse of antibiotics. And while doing that, sharing important clinical data with academia, industry, as well as integrated healthcare systems who have electronic medical record to utilize that information and come up with a shared clinical decision support system to guide appropriate antimicrobial selection. Now we understand that machine learning models have consistently shown superiority over traditional methods in all these studies that I shared. However, customization of prediction models is essential as the drivers of sepsis and the resources differs from one region to another region, and it is highly variable among various healthcare settings. It is vital to emphasize that AI algorithms are tools designed to assist rather than replace healthcare professionals. Their role is to augment clinical decision making, ensuring a collaborative approach in the patient management. Early recognition models must adapt to diverse healthcare environment. One size fit all approach is unlikely to succeed due to various uh, variation in epidemiology, clinical practices, and available resources across the institution. And one of the biggest limitation is that if the institution is not integrated with the electronic medical record, AI models will not be able to help in those settings in most likely situations. In conclusion, AI tools in sepsis management and appropriate antimicrobial selection promise enhanced diagnostic accuracy and timely intervention. Their integration, however, requires careful consideration of the ethical, logistical, and training challenges. I appreciate your attention and interest in this crucial topic. I look forward to your questions and insight on the challenges and opportunities in AI application for sepsis care and dealing with emerging antimicrobial resistance. Feel free to reach out to me at my email, and I will appreciate your questions and comments. Thank you.